Good evening. Today we're going to discuss the approach to a child with Down syndrome. Approximately 1 in 4 to 500 babies are born with Down syndrome each year. Therefore, every doctor should know how to manage a child. The best time to diagnose a baby with Down syndrome is at birth, or even before birth is in the best case scenario. Therefore, you can plan the best care for this baby and prepare the parents for the birth of their baby. A doctor should familiarize them with the physical features, the associated medical conditions, the risk of developmental delay and intellectual disability, how to make the diagnosis, and other diagnostic tests for confirmation of the diagnosis, as well as other screening tests, the management, and then ultimately genetic counseling. During the next 2 to 3 voice notes, I will give you a basic approach. You are a doctor in a rural hospital, and the nursing sister call you to the labor ward and ask you to come and have a look at a baby that she thinks is not normal. You soon realize that this baby has Down syndrome. What now? Down syndrome, also called trisomy 21, is a clinical diagnosis based on characteristic features. Can you name these features? Not every baby will have all the features, but some will be more consistent than others. I think at least 3 features should be present, as well as hypertonia to confirm the diagnosis. Now you have made the clinical diagnosis. Would you send this baby home the same day with his or her mother? No. You should observe this baby more closely. Observation should be looking at the saturations, how he's feeding, and if the baby is passing stools. All this is important as you are actually looking out for associated features. Saturations might be low because the baby is hyperventilating. Feeding difficulties might be due to the hypertonia or associated duodenal atresia. And the passing of stools whilst in the hospital is important because of the risk for Hirschsprung's disease. This will also give you enough time to order further tests. So how would you confirm your diagnosis of Down syndrome? There are different tests available, but currently we do a test called a QF-PCR. Stands for quantitative fluorescent PCR. This test is very accurate but can't distinguish between the different types of Down syndrome, as it only measures the quantity of fluorescent polymorphic markers on the chromosomes that's associated with aneuploidy. Thus, it is chromosome 13, 18, 21, the X and the Y chromosomes. It won't pick up any other abnormality and is therefore not a replacement for a karyotype or any other genetic tests. Other tests you should order would include a heart sonar, a thyroid check, and a full blood count. About 50%, 40 to 60% of babies with Down syndrome have a cardiac lesion, and the most common is an AVSD, atrioventricular septal defect. Most of these lesions are large, and you won't hear a murmur necessarily after birth. It is therefore important to do an echocardiogram, heart sonar, before 6 weeks of age. The risk for congenital hypothyroidism is also higher in children with Down syndrome than in the normal population, and therefore thyroid function tests should be done throughout life. We start usually with a TSH, which can be done on cord blood or after 72 to 48 hours after birth. A full blood count can detect hematological abnormalities such as a lymphoproliferative disorder as well as neonatal leukemia. This should be also followed up throughout life, as there is about a 1% risk for a hematological malignancy in children with Down syndrome. These babies should also be observed for symptoms of duodenal atresia, thus feeding but vomiting after each feed, and Hirschsprung's disease associated with the inability to pass stools and a distended abdomen. When this baby is now stable, you can discharge the baby, but this baby will need regular follow-up visits. We see very commonly blocked nostrils, recurrent upper respiratory tract infections, constipation, and other musculoskeletal problems. So during every visit, you should specifically ask for any of these symptoms and react accordingly. So babies with Down syndrome will need more care and more special care than other babies, and you, as the primary care physician, should be involved in their care. It also would be important to counsel the parents, and the first counseling should start directly after birth, when you tell the parents that you suspect Down syndrome. Both parents should be preferably present, and you should plan this ahead and use a discussion that is sensitive and empathetic. Nobody is ever to blame for a child with Down syndrome. Remember, no parent wants his or her child to have Down syndrome, and this would be actually a shock and bad news for them. So during this session and follow-up sessions, you can do what we call genetic counseling, where you would try and answer 5 questions. What is it? What is the cause? What now? What will happen? What's the management? Will it happen again? And how can it be prevented? So, what is it? We all know it's an extra chromosome 21, and there's 3 types: the non-disjunction, the translocation, and the mosaic type. The non-disjunction type is where you, under the microscope, will see there's 3 separate chromosome 21s instead of the normal 2. The translocation type, the extra chromosome is attached to another chromosome, either chromosome 14 or 21. And that pose the risk that this translocation already happened in one of the parents. So in these cases, you might want to do some genetic testing on the parents to determine how often this can happen again. The last type, and the least common, only 1% of babies with Down syndrome, is the mosaic type. That is where, if you look at the cells in the body, some might have the normal amount of chromosomes and the others the extra. What is the cause? We don't really know, but we know this happens usually, as in the non-disjunction type, during meiosis, where 2 chromosomes, homologous chromosomes, 2 of the same, align where there's homologous recombination, that's genetic material, exchange between the 2 chromosomes, and then those chromosomes need to separate. And that might not have happened in time. We definitely see an advanced maternal age can play a role. There's a lot of theories which include that our body naturally screened for abnormality, and in advanced maternal age the screening mechanism is not well developed, or that the non-disjunction happen in the ovums as a person is already born with all her ovums. So, in this case, obviously, advanced maternal age plays a role, but in many cases, you do find Down syndrome in younger mothers where we really don't know much about the cause. There's speculation of folic acid deficiency, obesity, but we don't really know. What now? So, in this case, you would be the doctor who plans everything. So, after birth, if there's a cardiac lesion, obviously refer to the cardiologist. If there's a gastrointestinal, the pediatric surgeon or the general surgeon is the best option. When the baby gets older, you might want to send them to the allied health professionals like speech therapists, occupational therapists, physiotherapists. Alternatively, when the baby has a cardiac lesion, the baby might fail to thrive, and in those cases needs extra calories, and you can refer to the dietitian. Later in life, during puberty or later, we should combat obesity, which is more common in children with Down syndrome, and the dietitian will definitely also play a role. So, you, as the custodian of this baby, need to organize all these different appointments and then double check that they are following. You also will, during your consultation, make sure all the blood tests is up to date and then also ask if the parents have any further questions. You will surely get asked, will it happen again? So, in the case of Down syndrome, we basically give a 1% risk of recurrence. Up until the age risk is basically exceeding the 1%. And that is around 40, 41 years of age. So, a 23-year-old with a baby with Down syndrome in the future pregnancy will have the same risk of about a 40, 41-year-old person. So we definitely would raise and screen this mother during a next pregnancy. You obviously need to tell her about her risk when she's older than 40 and has enough children. I don't know how much is enough, but three or more. You might want to tell her not to risk it again to have another baby. If the mother is young, you can now start to counsel her about prevention and their risk for a future pregnancy. So, how can it be prevented? There's not really much we can do to prevent Down syndrome, except an entity called pre implantation genetic diagnosis, where you do diagnosis of the fertilized embryo before implanting it into the mother's womb. They are doing that as you want a more viable embryo to start an in vitro fertilization cycle. Alternatively, you can tell them to drink folic acid to combat obesity, and that is called primary prevention. So, for secondary prevention, we'll be screening and testing. So, screening for Down syndrome, either in the first and the second trimester, will include a ultrasound screening or biochemical screening. So, ultrasound screening will entitle in the first trimester measuring the nuchal translucency. That is a measurement from the back of the spine to the end of the skin. And there's certain measurements according to certain gestation, and if it exceeds and it is increased, it might be pointing to Down syndrome. In the second trimester, you can look for soft signs for Down syndrome. That would be, your short femurs, absent nasal bone, also a echogenic focus in the heart or hyperechoic bowel or a cyst in the brain. That all are quite, non-specific, but might also help you to guide you in further testing. Biochemical screening also divided in first and second trimester. In the first trimester, It will be your beta HCG, beta human chorionitropic hormone, or PAP-A, placental derived plasma protein A, if I'm correct. Those measurements again depends on the gestation. If you compare it and load it in a computer with a maternal age, you will get a certain risk. In the second trimester, you have either your triple or your quadruple test. Your triple test, again, beta HCG, your alpha fetoprotein, and human estriol. If you then add inhibin A, it's the quadruple test. Sensitivity and specificity, most probably in a region of 70-80%. So since I started with genetics, they've been trying to get a better test. And we have now called cell-free fetal DNA, commonly also known as non-invasive prenatal testing or prenatal screening, where you look at DNA floating in the maternal plasma. DNA of the mother and the fetus is then compared, and you can then determine if this is a trisomy or not. Currently, it's only diagnostically used for trisomies, but I think in future you will do other conditions, even single gene defects, with this measurement. So this NIPT is still only a screening test, so you will only get a high or a low risk. In the case of a low risk, we can reassure the parents, never say the baby is completely normal, but you can then reassure the mother that the risk is low. If it's, however, high the risk, we will never offer a termination of pregnancy without doing invasive testing. Invasive testing, we have three procedures. It's your Corey-Honey-Villey sampling, your amniocentesis, and your chordocentesis, also called transcutaneous umbilical blood sampling. So the Corey-Honey-Villey sampling is done at about 11 to 12 weeks, and a needle with the suction catheter is introduced into the mother's abdomen, and a tiny piece of the Corey-Honey-Villey is extracted. The danger is a miscarriage, a transmission of HIV, or otherwise the risk for maternal contamination, where you actually take maternal tissue instead of the mother's. So only qualified gynecologists will do this procedure. Amniocentesis, done at 15 to 16 weeks, takes amniotic fluid on the ultrasound guidance. Those cells are cultured and then examined, and you can then get a more definitive answer. Lastly, the chordosynthesis after 20 weeks, where under ultrasound guidance you take a sample from the umbilical vein or artery, I prefer the vein, that will be then yield a faster result. The risk for a miscarriage is also there. Thereafter, you can only counsel the parents and say that there is a case of, Down syndrome or any of the other trisomies, and then the parents can decide if they want to continue with pregnancy or not. I think this is a very delicate, and we usually make use of genetic counselors for those discussions, but in the absence of a genetic counselor, you as the doctor might have to do it. We say we do non-directive counseling. We don't tell the parents what to do. They must make their decision. We just give them all the information and then guide them into whatever decision they want to make. This, I think, is the most difficult decision that any parent will make in his life. And no matter what they decide, it's not going to be an easy decision. So I do think you need to treat this with empathy and very professional. But I hope this will help you in managing your child with Down syndrome, and that you will be able to, deal with such a child and treat the child appropriately and with dignity. Thank you. We will discuss this in our session when we discuss the approach to a child with Down syndrome. Bye bye.